let's move on to our first panelist from the national scene, and that is George Pink. It's my honor to introduce Dr. Pink. He's Deputy Director of the North Carolina Rural Health Research Program at the nationally known Sheps Center for Health Services Research in North Carolina. He's also the Humana Distinguished Professor in the Department of Health Policy and Management at the University of North Carolina at Chapel Hill. Through his work over the years and at the Sheps Center, George has an excellent view of healthcare availability and accessibility across the country. It's an honor to have you, Dr. Pink. Thank you so much for joining us.
Thank you very much, Barbara. I appreciate the invitation today. I'm going to start by uttering two phrases that you never hear in the same sentence. I'm a professor, and I'll be brief. So I'm going to talk today about some work that we are doing for the Federal Office of Rural Health Policy and the National Advisory Committee on Rural Health and Human Services. And specifically, I'm going to talk about the new Rural Emergency Hospital. Next slide, please. So I'll briefly describe the models, talk about the policy question that we were recently asked to address, go through some of the comparisons between closed and open hospitals that we've used to guide our research. And then I'm going to talk about how we estimate the number of hospitals that might convert to this new model, and then briefly discuss some outstanding policy issues. Next slide. So the Rural Emergency Hospital, what is it? Well, the Consolidated Appropriations Act of 2021 created a new facility called a Rural Emergency Hospital. This is quite a big news in the rural world because it is the first new Medicare payment classification in 25 years. So these do not come along very often. There's a lot of speculation about how this got into the act. I can't find anybody who actually knows where it came from, but the speculation is that Senator Grassley and Senator Klobuchar, who's co-sponsored a bill which for similar kinds of facility that they were the origins, but I'm not sure. What is it? Well, it is a facility that is, the legislation states explicitly, it is aimed at communities where there is high likelihood of the local hospital closing, rural communities where there's high likelihood of the hospital closing. And this, again, as Richard was talking about, this is no strange phenomenon to Tennessee, given that there have been 16 closures since 2005. How is this designed to fill the gap of a facility that might be facing closure of the inpatient facility? Well, it will provide emergency department care only. There will be no inpatient care at all. There'll be observation beds. There'll be a wide range of outpatient services, and some facilities may choose to have an optional SNF as part of the facility. And emphasizing again that they do not provide acute care inpatient services. There are no beds for inpatients. They will still have EMTALA. They still have to treat everybody who shows up. And very importantly, they can be an originating telehealth site, which will be important to maintaining access in very rural areas. Next slide. How will they become, essentially, who can become an REH? Hospitals that are currently licensed as a critical access hospital or a PPS hospital with 50 beds or less are eligible to apply to convert to a rural emergency hospital. They have to include an action plan, the services that they're going to provide, how the facility payment, and I'll talk more about that in a second, will be used. And the state of Tennessee, in your case, will have to approve licensure of these facilities. Next slide. What are some of the specific requirements in the legislation? A patient cannot be in the facility more than 24 hours. It has to be staffed 24 hours days, 7 days a week by a physician, nurse practitioner, or any other sort of advanced practice provider. There are proposals so that these people may not have to be physically on premises, but within 30 minutes of being physically present. There will be Medicare licensure requirements. Essentially, have all the requirements of an ED that's in a hospital. Importantly, there'll have to be a transfer agreement placed with the level 1 or 2 trauma center. Believe it or not, there are lots of hospitals around that do not have such agreements. They'll have to make conditions of participation of the CHs, and if they choose to have a SNF, they'll have to meet the distinct part unit requirements. Next slide. I won't take you through, this is my world. I'm a finance professor, so I love this stuff, but I realize people on the call may not be as intrigued as I am. The most important part of the legislation, and I'm going to show my bias here, I am a finance professor, but in my opinion, this model will not work unless the finances are there. The good intentions and access and quality are all great and extremely important, but if there's not a financial case, I am skeptical this model will succeed. So a lot of attention is being paid to the proposed funding of these things. Right now, the major component is what they call this a monthly additional facility payment. And very quickly, what they're going to do is they're going to add up all of the money that Medicare paid to critical access hospitals in the United States as of the end of 2019, that 1 year. How much were they paid in 2019? They're going to then estimate what would those hospitals have been paid if they in fact were still prospective payment system hospitals. The difference between those two numbers is going to be the premium that the monthly amount, divided by 12, is going to be the monthly amount that these rural emergency hospitals will receive as a sort of a subsidy to providing care in that community. I'll give you some estimates how much this will be in a few minutes. There's enhanced outpatient reimbursement. There's a 5% bonus to outpatient reimbursement, and basically everything else is the same. So the open question really is, will this monthly additional facility payment and the increased outpatient payment be sufficient to have a business case for these kinds of facilities? Next slide, please. Quality metrics are specified. They'll be required to submit data. They'll be made public. They'll be posted on the CMS website so people in the communities will know how they're doing. And then there'll be an extensive evaluation process. Next slide, please. Okay, how has this been received so far? I'm going to put optimism and skepticism. I'm an academic, so I have to give both sides of the argument. There have been people who have expressed general enthusiasm and encouragement that this could be an alternative for communities facing hospital closure. And I will repeat that this model is designed specifically for communities facing hospital closure. It's not designed for hospitals or communities where the hospital is thriving in the community. There's a lot of skepticism. As soon as you say that, I've several people with whom I've discussed this model. As soon as you say that CMS will be calculating the monthly facility payments, there's immediate skepticism about whether CMS knows what it's doing, whether it's going to be using the right models with the right data, and so on. There's no mention of capital in the legislation. Many people believe that the existing hospital buildings will not be usable for rural emergency hospitals. They're designed around inpatient beds, and these facilities will be outpatient-only facilities. There's a fair amount of skepticism from the community resistance. I've talked to some operators of freestanding emergency departments in the freestanding emergency department capital of the world, which is Texas. And they say that community resistance is a big factor, because essentially you're going in the community saying, guess what? You've got an inpatient facility with 150, 175 employees. We're going to replace it with a freestanding emergency department where you've got 25 employees. That doesn't go over too well with the community. So there's a real sales job that's required. There's some concern that for-profit systems or large healthcare systems, urban-based systems, may just close the facility and use REHs as a cost-saving strategy without really caring about access. The last point's trivial. So next slide, please. So the question that we are asked is, we got this brand new Medicare designation. We have no idea how many hospitals might be interested in this new model because we have no historical experience with it at all. So we were asked by the National Committee to estimate the number of rural hospitals that might be interested in this. Prior to our work, I heard guesses of none because the financial model is not there, to maybe 100 early adopters, if you like. So I'm just going to briefly describe how we estimated the number of hospitals. And I think this will give you hopefully some idea of the types of hospitals in Tennessee that might be interested in converting to this model. Next slide. So the way we started, like, you have to forgive me, I am a professor. Our basic hypothesis is, well, let's look at the characteristics of rural hospitals that closed in the last 10 years, because we think that those characteristics might be predictive of hospitals that are still open today, but might be considering conversion to a rural emergency hospital. So what we did is we compared a whole bunch of financial and community characteristics of hospitals that are still open to hospitals that closed over the last few years, and identified where the similarities, if you will. And then we just selected a bunch of measures to sort of be selection criteria for hospitals that are likely to consider conversion. Next slide. So here is a table, and again, some of this is pretty dense, so I apologize for that. But just to clarify as well, we differentiate, the Rural Center North Carolina Rural Health Research Program, we differentiate between what we call complete closures and converted closures. So complete closures are literally, there are no more healthcare services provided in the building. I mean, the building is either now vacant, or it's an apartment building, or it's an office building, or it's been blown up. Converted closures are hospital closures where there is no longer any acute inpatient care provided, but they morph into something else, like a SNF care, rehab care, or primary care, or something like that. The majority of closures are complete closures, about 61, 62% of all closures. There's nothing left in the building, no healthcare services left in the building at all. So what we're doing here is we're comparing the hospitals that were complete closures from 2011 to 2020 with hospitals that these are all less than 50 beds, because remember some closures have been greater than 50 beds. So this is a subsample really of closures. And there's 53 hospitals that converted in that same time period. We're comparing it to 1,679 hospitals less than 50 beds that were open as of the end of 2020. So you can see that there are substantial differences between hospitals that closed and hospitals that remained open. The most obvious being much higher levels of unprofitability, much lower patient volume. ADC stands for average daily census. Hospitals that close are more likely to have, or less likely to have a rural health clinic, and they're less likely to be government owned. Next slide, please. The majority of hospitals that closed were prospective payment system, critical access hospital, and Medicare dependent hospitals. And you can see there's a big difference between these and the ones that stayed open. Next slide, please. Where were they? Again, this is, as anyone who has been following the rural hospital closure saga will know, that this is primarily an issue in the South. The majority of rural hospital closures that have happened in the last 15 years have been in the South. Tennessee, Oklahoma, and Texas being three of the largest states where the largest number of closures has happened. Next slide, please. So we decided how we got these interesting comparisons here. So we actually went to a conference And we asked the participants at a conference about 3-4 months ago, what do you think are the most likely reasons, or the hospital characteristics of hospitals are most likely to consider conversion? And the three most common answers we received from the people in the audience, it was a mixture of hospital folks and policy folks, was long-term unprofitability. I mean, that is by far the most important determinant of rural hospital closures. These are not, we lost money last year, let's close. These hospitals have typically been losing money for years and years and years. Low inpatient volume. So if you're only got 1 or 2 patients in the hospital on any one day, then that again is likely to be a facility that might consider conversion to an outpatient REH facility. And then finally, a small amount of net patient revenue. The smaller facilities just don't have the volumes and the profitability and the revenue to make it worthwhile. Next slide, please. So using those 3 criteria, we've isolated all the hospitals, the rural hospitals that are currently open, but meet each of those 3 criteria, i.e. they've had 3 years of negative total margin, they have an average daily census less than 3, and they have net patient revenue less than 20 million. And we identified 68 hospitals that meet those criteria. And so you can see there's of the 68, 100% of them each meet those criteria, because those are the criteria we use to select them. But you can see that they're very different from the hospitals that are other hospitals that are remaining open at the end of 2020. Only 14% of the 221 hospitals had 3 years of negative total margin, for example. Then at the bottom as well, we can see that there's a much higher percentage of government owned, and there's a lower percentage of system affiliated. Next slide, please. Critical access hospitals by far we estimate will be the kind of hospital to be most interested in conversion to a rural emergency hospital. I was surprised the number of Medicare dependent hospitals was as low as it is, because they've faced some real difficulties as well. But these are the criteria. Again, if we chose different criteria, we'd get a different list of hospitals. So there's a lot of potential error with these estimates, of course. Next slide, please. Again, where are they? At the West North Central and West South Central, which is not a surprise. It's consistent with our patterns of closure. Next slide. What are some of the characteristics of them? The 6 to 8 hospitals, the average loss over the last 3 years has been a negative 6.9% total margin, a negative 12.8% operating margin. So these hospitals are in really, I would consider, fairly desperate financial condition. Only 1.6 ADC, so they are hardly. Can you describe the difference between a government-run and a system-run hospital? Government ownership is a county or some government agency that owns the hospital. System-run membership is, for example, a hospital corporation or healthcare corporation of America is a for-profit system, and it owns a lot of rural hospitals. And there are large systems that are not for profit who also own rural hospitals. I think Tony, Adam is going to be talking. Adam Insuring is going to be talking specifically about that question when he presents in a little while. So I'll defer to him on that. Again, just looking at the other characteristics of these hospitals, have got low patient volume. They're very small, only 7 million a year in revenue, and a very high Medicare inpatient mix. Next slide, please. We at the Rural Center, we produce a financial distress index model. Essentially what it is it's a fairly complicated econometric model that predicts the risk of financial distress 2 years hence. We run it for all 2,200 rural hospitals across the country every year. And we essentially take all 2,200 hospitals and we put them in one of 4 buckets: high, mid-low, and low. So again, that model is independent of the research that we've been doing up till this point in terms of what I've just been describing. but we felt it was important to verify that of the 68 of the hospitals for which we had financial distress data, most of them were at high or mid-high risk of financial distress. So again, this confirms that the 68 hospitals that we think are sort of typical of the hospitals that might convert are under a lot of financial pressure. Next slide, please. So I can't see what that is. Okay. Can you go back one slide, please? I'm not sure anybody can see. Oh, you can't. So I don't know why that's not showing, but I think what that shows is that the unemployment rate in counties where REHs are most likely to consider conversion, they've got a much higher unemployment rate, which again would be consistent with the financial distress. Next slide, please. This shows that, again, the REH converters are more likely to be in very small communities with low population density. Next slide. Where are they? I know everyone's going down the list looking for Tennessee, and it's at the bottom there. 2 of the 68 we estimate might be in Tennessee. By far, Kansas. You think things are bad in Tennessee? Go to Kansas. There are huge numbers of hospitals that are losing money. Texas and Nebraska and Oklahoma are those 4 states. Almost half of all the 68 are in those 4 states. And then there's a whole bunch of states like Tennessee with 3 or 2 hospitals that we think might be interested in converting. Next slide, please. There are many outstanding policy issues associated with rural emergency hospitals. I'm not going to talk about all these in detail. I'm just going to give you an overview of what they are. And right now, CMS has a public commentary period until November 3rd or 4th, I think it is, where they are inviting people, organizations, and individuals to submit comments about the policies and the legislation, the rules and regulations that our CMS will be issuing. These 6 policy issues that I'm going to briefly describe, they seem to be on the radar screen of most rural health advocates and most rural health organizations around the world. Next slide, please. So the first issue, and again, these are just questions that they want answers to that people think are important to answer. Right now, there have been 16 hospitals in Tennessee that have closed since 2005. Will they be eligible to reapply to become one of these rural emergency hospitals? Right now, the legislation says they're not eligible. Why not? But the legislation said they have to be currently licensed as a hospital. So if the hospital closed and a license is expired, those 16 would not be eligible. Similarly, if suppose people in those 16 communities come together and say, we think we can make this model work in our community, let's put in an application. Right now, that you can't do that because you don't, if the license has expired. The steps and the timing consideration, how long is this going to take? What are the specific conditions of participation that are going to be imposed? And what supports and timelines are states to establish licensing rules? There are some states that do not have any licensing rules. They don't have any freestanding emergency departments, or if they do, the rules and licenses for them are not as well developed as will be necessary for a rural emergency. Next slide, please. Payment is the big thing. Again, my bias is I'm a finance professor. I believe payment money drives everything. Glass half full approach. John Hawkins, who was vice president of Texas Hospitals Association, he thinks that there's a lot of hospitals in Texas. They'll take advantage of this. There have been some hospital industry groups who think that the law, as it's written, will allow CMS wide flexibility to boost payments if they are found to be insufficient. Again, that's one interpretation. So there's the glass half full. The glass half empty is on the next slide. This is the first Christopher Matthews was quoted. He's an actual CEO of a hospital in Kansas. He doesn't just doesn't think the reimbursement is going to be enough to make it worthwhile. They still need medical staff. They still need the billing staff, registration staff to keep the ER open. It's just not going to be financially viable. Harold Miller is also concerned because right now the law says that every single REH would get this exactly the same facility payment. There's no adjustment for volume or facility characteristics or location or the community they serve. It's just a standard amount per month for everybody. Next slide, please. How much will the actual payment be? There are various estimates out there. The PYA, a healthcare consulting firm in Kansas, did the estimate, and they said about $1 million a year for the average hospital in Kansas. The National Rural Health Association estimates 2.9 million. The next slide, please. We did our own estimate based on all kinds of the assumptions that you see there. We estimate about $1.7 million per CEH. So the $60 million question is whether 1.72 million to 2.5 million, will that be enough to maintain the overhead and the facility services necessary to maintain a rural emergency hospital? Most people with whom I have talked said it won't be. So we'll see what CMS comes up when they issue their rules and regulations in the spring of 2022, and we'll see what the numbers actually look like. So this is a big open question. The scope of services payment, what will they also be available at enhanced REH? Not just the outpatient rates, but the lab rates, for example. Will the rural health clinics, will they still be able to maintain some of the grandfathering provisions? The RHC payment method has been revised, and will that be the new method or the old method? The method 2 payment for physician fee schedules for critical access hospitals, will that be maintained? We have no idea how state Medicaid programs are going to pay for REH services. Like, I'll be interested to see if anybody has any speculation about that for Tennessee. And again, a big problem, I think, is that there's no mention of the capital legislation. Now, I have been contacted by various senators, staffers saying that the administration is attempting, there are several senators attempting to include capital for REHs in the proposed infrastructure legislation that's before Congress. Next slide, please. EMS, I think a lot of people are starting to get concerned about the role of EMS. As we all know, there's a high amount of variation in the quality and the extensiveness of EMS in rural areas across the country. There are, and of course, if we have rural emergency hospitals, many believe that they will be essentially outpatient facilities which transfer a lot of very sick people to trauma centers. So there's going to be more transfer volume, which will impose more volume requirements on EMS. And are our EMS systems adequately prepared for that? In many areas of the country, they are. In many areas of the country, they are not. Next slide, please. Transfer agreements. Again, you would think that most rural hospitals have got long-standing transfer agreements with trauma centers, but that is not true. There are many rural hospitals that just transfer their patients to a local hospital that may be a level 1, level 2, or level 3 or 4. So for some hospitals, the rural hospitals, are going to have to develop these transfer agreements from scratch. And of course, there are a lot of financial incentives that against larger trauma centers receiving patients from small rural hospitals. So those, giving incentives to the trauma centers to receive transfers from REHs needs to be thought through. Next slide, please. Staffing, there's huge shortages of physicians in rural areas, as all of you know, particularly emergency docs. There's some data on the next slide, please. And you can see, you really can, it's too small. I should have made it bigger, I'm sorry. And what it shows is shortages in the emergency medicine physicians as well as advanced practice providers in rural areas. Next slide, please. Thank you. We do not have a lot of science and a lot of experience with reporting quality emergency area or rural emergency care, and there's been a lot of problems with it. But nevertheless, we're going to have to develop those and report it. Next slide, please. So to conclude, because I want to conclude before my time, the positivist, the optimist thinks it could be an important step to preserving access. However, the devil is in the details. The future rulemaking and guidance will be absolutely critical, and CMS, I think, is making an honest effort to listen to rural providers and make this model as feasible as possible. Thank you very much.
Thank you so much.
Sorry, I was just looking at this chat. Does have licensee option, so that be sufficient or new license category needed. I do not know the answer to that.
Okay. There are considerable questions that will have to be resolved, as we know. Building on that question from Claire Sullivan, you mentioned in your presentation that Tennessee has, based on your analysis, 2 predicted converters, hospitals. Does any state, or would it be a useful idea in Tennessee for us to establish something like conversion teams that would assist rural hospitals and rural communities in understanding the implications of this new opportunity? And has that been done anywhere?
Yes, it's an excellent idea. It's an excellent comment. Kansas, the Kansas Hospital Association has got exactly such a support team. They're working with local hospitals in Kansas who might be interested in this new model. So I think the situation in Kansas is so desperate that the Hospital Association is taking a very proactive role. So I would urge you, or I would suggest that you contact the Kansas Hospital Association, talk about some of the preparation, some of the assistance packages that they're putting together, and the kind of work that they're doing with hospitals there to help the board and the management, first of all, decide whether this is a direction they want to go or not, to talk about the requirements for preparing an application and what the consequences may be on the community as well, because there will be consequences.
Right. Right. Thank you, George. Another question we have is, what is the date that hospitals might be able to apply for this conversion?
Yeah, the applications will open in 2022, and the first REHs will go into existence in 2023. I think it's April 1st, but I could be wrong. But it's 2023 will be when they start going into operation.
We have a comment that local organizing may be important here to help communities understand and follow through on this possibility. Is that your sense? Do you have any feeling for that?
That is my sense. I absolutely agree with that comment. For some of the reasons that Richard talked about earlier on, that sometimes when a hospital is about to close, we've studied closures a lot over the last decade, and I'm astounded how many people I've talked to who, when the hospital announces it's closing, the community had no idea that this was going to happen. The community had no idea the hospital is in financial straits. So having a wide awake, aware, and an engaged local community is absolutely essential. As well as, and I'm just being blunt here as well, that frankly, the communities that are most likely to jump on this kind of new model are the ones that are facing closure or nothing. I mean, closure, having an REH or nothing. If there's any possibility the hospital keep going on, I think the community will fight back. But if the only alternative they face is, if the options are closure or a rural emergency hospital, I think communities will look at the rural emergency hospital. But it'll be important to engage the community in seeing this is truly the only option that we have facing us.
Well, that was certainly the experience of our rural community. That they're, in fact, independent from us, the suggestion for freestanding ERs came up often in communities, recognizing that they couldn't really support a full-scale hospital. And we have a question from the group, actually from Rich, about that. How are existing freestanding ERs financed now?
Yeah, so as I mentioned, Texas is sort of the freestanding ED capital of the world. I think there's 110 of them in Texas because it's not a CON state and anybody can build anything anywhere. And essentially, there are very, very few freestanding emergency departments in poor rural areas. They just are not financially viable. So where are they? Well, most of them are in well-insured suburbs of larger cities, and where they got a good payer mix. They're highly profitable because they're young families like going to them because they don't have to sit in the hospital in safety net hospital emergency department. They go to a nice clean new facility in their suburb. So there's not a lot under existing payment rules. There is very few rural communities is there a business case for a freestanding ED. And that's what the rural emergency hospital, that's why it has this additional monthly payment. And that's why it has enhanced outpatient payment, because basically current existing rules just don't allow a financially viable model.
Well, we've had a number of questions regarding just this problem. And in our case, specifically the connection between our state's failure to expand Medicaid and the rural hospital crisis. But you seem to be suggesting that simply Medicaid without the presence of private insurance would not be enough to support a freestanding emergency room. Is that correct?
Not in my opinion. I mean, I'll be interested to see what Adam says.
Okay. We had a specific question, hoping that you could explain the difference between government-run and system-run hospitals.
Yeah, I tried to do that during my presentation, but it's not really government-run, it's more government-owned. So county hospitals, city hospitals, hospitals that are owned by a county or city or some local government entity are what we call government-owned facilities, as opposed to not-for-profits that are owned by a religious organization or a university or something like that. What we call system-affiliated hospitals are hospitals that are owned or managed by larger healthcare systems. So UNC Health, for example, has 3 rural hospitals. So it's a huge academic medical center-based system that's got 14 hospitals in it, which 3 of which are rural hospitals. That's the difference. Right. They're really two totally different things. One is ownership and one is system affiliation.
Right, thank you. In the earlier part of your presentation, you talked about the lack of capital support. Have there been any creative approaches to that? And is there the possibility for that? Or must the new designation take place in the same physical building as the original hospital?
No, there's nothing in the legislation that says it has to be the same building. In fact, I would say from all the people with whom I've talked to who run these kinds of facilities or very small facilities like this, that the existing hospital buildings will not be economically viable. Essentially they are convinced that to have financially viable rural emergency hospital will require you blowing up the existing building and building something, like a tenth of the size, no inpatient rooms, and a totally different workflow process than what is in current facilities. Now, having said that, I've talked to a few people who think they can make their existing building work. So I'm skeptical. I think it will require a new facility. The first part of your question was, have there been any innovative ways of, well, we don't have these facilities yet, so it's hard to say that there's innovative ways of financing these things. But let me just say quickly that, when you look at a lot of rural hospitals, if we go back to our system affiliation discussion a minute ago, the way that a lot of rural hospitals have been able to keep their physical plant updated is, they join a system, and the system supports them, subsidizes them. And that's certainly the case in my area. Like I was just saying a minute ago, UNC Healthcare, they bought several small rural hospitals. They've poured a ton of money into those rural hospitals. Some of them are now, it's taken them a decade to turn around to the point where they're now profitable. But that's the way many rural hospitals survive. They join a system, and then the system is the source of the capital. So that's not innovation, but it's a way of survival.
Right. Thank you. Tennessee Healthcare Campaign is, to a great extent, an advocacy organization, and we spend a lot of our energy working with state legislators and policymakers around these kinds of issues. In terms of the process that you're talking about now, is there a role for local advocacy aimed at our national representatives to make this move forward?
Well, let me just say, Barbara, Adam Insuring is running for town council of Chapel Hill, which is where I live. So if he agrees to answer these complicated questions, I'll vote for him. So I don't know the answer to that. I'm just a finance professor, but I think more advocacy is always probably better than less advocacy. I think a lot of the challenges that Tennessee has are probably not that different to the Kansas and to other states that have experienced a large number of closures. I think Texas is probably pretty different from well, maybe not. I don't know. You could tell me whether Texas is really different from Tennessee. But I think Tennessee and Oklahoma, for example, and Georgia has had a lot of closures as well. I think that those states have got a lot in common, and probably a voice at the national level, which represents a collective voice of states that have really experienced a lot of closures, probably would be a good thing. But I'm just a finance professor. I'm politically challenged.
Well, we appreciate your input. Sometimes that's the best kind from the non-professional. One last question before we move on to Adam Insuring. We've seen big problems with patient transfers with COVID. Do you think that the effects of COVID will influence transfer agreements under this model?
Yeah, I suspect they will, as long as COVID is such a huge problem. And again, this is so, as the report that came out yesterday, I was on NPR this morning, was saying that, nationally the trends look good. It looks like we're going down over the longer run, but there's still going to be local areas where COVID is a huge problem and will remain a huge problem probably through the spring. In those areas in particular, where we've got urban centers that have got ICUs that are 110, 120% occupancy rate filled with COVID patients, it's going to be tough. It could be very difficult for rural hospitals to get their patients transferred to those kinds of facilities. And in fact, one of the things that started to drive me a little crazy was, on the news 6 months or so ago, which prompted us to actually issue a findings brief on this topic, some VP of an urban hospital saying, well, we want to ship all our COVID patients out to the rural hospitals. They got lots of space out there. So those kinds of combative relationships don't help. And I have no doubt that what you say is true. That in many areas, it's going to be continue to be a problem.
Well, let me just say on behalf of our group here, both to you and Rich, George, thank you so much for a thoroughly stimulating presentation.